On May 5, 2009, President Obama unveiled a 6-year, $63 billion global health initiative. GHI would continue U.S. leadership in global health by systematically building on the success of the Bush administration's President's Emergency Plan for AIDS Relief, or PEPFAR, and the President's Malaria Initiative, or PMI.
The successes of the last decade came about in the midst of an emergency crisis. U.S. leadership was able to create vital new platforms, PEPFAR, PMI, to bring mass benefits to people in low-income countries for HIV, AIDS, TB, and malaria, and to build bipartisan support here in the United States and bring adequate resources. The Obama administration is building on those successes. It's enlarging the scope to include maternal and child health and neglected tropical diseases, and it's introducing new principles for the way we go about doing business.
These principles include a woman and girl-centered approach, strategic coordination and integration both within the U.S. government and outside with key multilateral organizations and the private sector, greater country ownership in budgets, personnel, and services, strengthening health systems to build sustainability, stronger metrics and monitoring, and active promotion of research and innovation. Funding for the programs now included in GHI increased dramatically in the last decade. President Obama has proposed further increases that would bring GHI to $9.8 billion in 2012. But with a protracted U.S. economic downturn and split power in government after the November 2010 elections, there are questions about whether substantial new resources can be delivered.
This is an age of budget crises, uncertainty, and all foreign assistance programs are subject to much higher scrutiny. Global health is not exempt from that. The challenge right now is to prove to the American people and to Congress that these investments in global health are high impact in enhancing and raising the lives of people, saving lives, that they are cost effective, they are best buys, and that they're worthy of being preserved and sustained into the future.
With growing debate in Washington about foreign assistance and curiosity about how GHI was faring in key countries, CSIS traveled to Kenya to see what GHI means on the ground, how it changes the way the U.S. does business in health, and whether this new model shows promise of real and sustained impacts. The national atmosphere in Kenya is cautiously optimistic. After a peaceful August 2010 constitutional referendum, which calls for devolving power to local authorities and strengthening good governance, there is widespread, if tentative, hope that Kenya has escaped the instability and violence associated with the December 2007 national elections.
I believe an important element in the new constitution is that it decentralizes decision-making and financial management from the central ministries to counties.
You can bet the local authorities will want to take over as much as they can of the health sector and education sector and everything else. And a lot of that is to be devolved to local authorities. But how? None of that has been worked out. So to be honest with you, it's quite a wild card. And of course the big fear is that corruption will just be devolved to the local level.
As Kenya undergoes major shifts in its governance, GHI represents an opportunity to build on the past successes of programs like PEPFAR, which provides 400,000 Kenyans with antiretroviral therapy and represents the lion's share of U.S. health assistance to Kenya.
The Global Health Initiative is an opportunity to take the success of the last 10 years, the considerable success that we've seen under the PEPFAR program, the President's Malaria Initiative, etc., and build on that success to develop a set of integrated interventions that meet the needs of people like the people here in Kenya in order to have greater country ownership, more of a focus on women and girls, so that we have a more effective and more sustained response.
The U.S. interagency team spent an intensive 6-month period reviewing the USG health portfolio and assembling an integrated plan that focuses on 5 select GHI principles. The first principle is improved interagency planning and coordination with the government of Kenya.
We see an opportunity here for the various partners to create collaboration and actually utilize the existing resources by addressing unnecessary competition or repetitive working and resources being directed where it is required most, and then looking at the health system so that sustainability is achieved, efficiency and effectiveness in the health service delivery.
The second principle is using stronger metrics and monitoring to drive results. In Kibera, one of the poorest urban communities in Africa, the CDC and the Kenya Medical Research Institute have set up a population-based surveillance system and partnered with an NGO, Carolina for Kibera, to provide a range of health services.
The type of information that's collected here, as well as in the sites that we operate in Western Kenya, in rural Western Kenya, will give us information that will allow us to focus efficiently programs to improve access to obstetric care, as an example, emergency obstetric care and routine obstetric care and antenatal care, which we think will make a big impression on maternal mortality.
The greatest impact that we've been able to see has been the health-seeking behavior. Initially, when we did the health utilization survey, so many people were not visiting the clinic. However, currently the enrollment rate and the acceptance rate of the program has been like 98% people, whom we see here as study participants.
In the future, CDC KEMRI will use the data collected in Kenya to support the GHI's new focus on maternal and child health by designing efficient programs to reduce maternal mortality. The third principle is integrated services with a focus on maternal and child health.
The big issue in Africa and in Kenya is maternal mortality. The numbers still remain very high, and it's something that needs a lot of effort, a lot of intervention, and it's our hope as citizens of Kenya that donors can begin to own what our governments are putting forward as priority issues to address some of these glaring areas.
In Western Kenya, the value of integrated services is already being documented. The PEPFAR-supported AFIA program, led by USAID in conjunction with PATH and a consortium of US NGO partners, are using the maternal and child health clinic as the entry point for women and their babies to receive integrated health services.
Well, the AFIA program, to some extent, is a really good example of some of the key principles of the GHI, particularly the principle of integration and movement towards country ownership.
Most of the services that are integrated, we have family planning services which have been integrated. We have HIV care services that have been integrated, and we also have the testing for those who do not know their HIV status, which we have also integrated. So when you go to the rooms, everything is just done in the room.
Typically, when a mother comes for the service, both for herself and for the child, it takes not less than 4 hours for that one service to be given. So you can imagine if a mother came for family planning and at the same time came with a child to be immunized. It means that she'll have to go to 2 separate departments within the same institution. So you are talking about 8 hours.
Mothers kept on complaining their movements was too much. Move from one room to another, go here, and it was time consuming. At the end of it all, they stayed longer in the hospital, and even sometimes they ended up not getting all the services that they needed. There was no confidentiality, and there was no that client satisfaction.
So by doing these integration services, we wish to cut this time to the minimum. If the mother can be in that institution for maximum of 3 hours, we think that would be very helpful to that family.
But there are obstacles to introducing integrated services, and that's why in Kenya, the USG is focused on a fourth principle, which is improving health systems by investing in people.
The major setback in terms of integration services is the human resource. Because when integrated services, it means that you want to get clients nearly at the same time for the same services. So you need more hands with relevant skills.
And a crucial part of increasing human capacity is related to the fifth principle, which is to achieve greater country ownership by deepening the commitment of partner governments to increase budgets, personnel, and political will to expand health services and capacity.
Those facilities are being run purely by Government of Kenya staff. We have trained the staff, we have built the capacity of the staff, we have improved the infrastructure, and we have made the institution to own the whole process so that they are not dependent anymore on us.
As GHI unfolds in Kenya and other countries around the world, significant challenges remain. But we've seen that U.S. health investments can improve lives and help create more resilient communities. The world's expectations for U.S. leadership are high, but we can and should rise to meet them. The goal of reducing global death and disease and creating more resilient, self-sufficient partner countries reflects America at its best. With creativity, goodwill, and bipartisan support, GHI offers a vision worth pursuing and a smart plan for meaningful U.S. engagement in global health.